Thank you very much for this opportunity to come and talk to you today. Thank you to the Patricia and your chair committee, your chair and the committee. Thank you for your sponsors to hear about what we are doing in Alberta. And as was mentioned, Dr. Catherine Todd had planned to be here, and unfortunately, because of an emergency, she could not make it. And so I'm going to try and do justice to her slides. It's always tough speaking for somebody else. Never quite sure. And Dr. Todd was instrumental in development of the networks, leading the networks. And so she really is somebody who has a really good understanding of what the type of work that we're talking about today. First, I'm going to talk about a little bit of what the why networks and why did we launch them. And then I'm going to use an example of the Bone and Joint Network, which is my role. I'm a senior medical director for the Bone and Joint Network, and some of how we think we've been successful and some of the factors that led to that success. First about AHS. So AHS was our experimentation. You're going through some changes now. We did this in 2008, where Alberta brought all the health regions and the health, everything together into a fully integrated health system, Alberta Health Services. And Alberta Health Services, we have about 650 facilities across the province. We've got 9,000 plus physicians. It's the largest employer in the province and the fifth largest employer in Canada, actually. So it's a huge organization. And there were some efficiencies in developing Alberta Health Services. We heard last night whether some of these changes, are they good or are they bad? Well, from where I stand, this was a good thing. For us to do provincial planning, provincial organizing across multiple facilities, this was a really good thing. There was also some good things, and we have listed there as 3%. We spend the least on administration of any other in any other province in Canada. So there were some real efficiencies in money spent on some of those areas, but from a physician leader to be able to work across the province, because there was a lot of competition between Calgary and Edmonton. We do it better here, we do it better there. We don't want to share information with our colleagues down the road just in case. So actually, from our point of view, that was a very good thing. And out of that restructuring came the concept of strategic clinical networks. And this is a slide that was put together by Cy Frank. Cy was one of the leaders in developing the networks, and this was his view, is that this is how the network should work. He wanted to start with incenting innovation, liberating health data. We knew we had a lot of data, but we had to liberate it. We had to be able to use it and translate it back to the important people who needed to use it. We had to apply that knowledge, and then we had to innovate. And so the purpose of this was their dream was that the SCNs would be the engines of innovation in Alberta. So that's interesting. I didn't know that her slides did this. So we had known that networks worked in other centers. We looked around the world and we know that networks had been shown to work. I'm going to go down all her slides. But really what we wanted and what we needed was we needed an honest broker. Like I said, there was a lot of competition between different sites, different cities. Everybody thought they had the answer, and we needed an honest broker to help solve some of these complex problems across the province. We knew we had huge inequities across the province. How we delivered care was significantly different in one area than another. We also needed to engage our clinical partners. There wasn't really a structure in place for clinical engagement, and they needed a structure where they could see how they could speak into the process, how some of their good ideas could be scaled and could be spread forward. And that was kind of the reasons behind why we chose strategic clinical networks. The network structure itself started with a core team, or what I call a core committee. And that was kind of the center of the network. A core committee includes an administrator, a physician, group. We have about 20 to 30 people on our core committee. And the core committee directs that network. So that group of people, that has representations from senior leaders from administration, and we really want those senior leaders because they have to speak into it. We have nurses, pharmacists, we have people from the community, we have patients, patient advisors, and we really expect that core committee to speak into what should we do in this network. Out of that core committee, depending on what we're working on, will come working groups and support teams. And those working groups will pick an area. For instance, if they're working on fractures, they'll work on fractured hips, and that working group will be then related to that. Outside of that, we want them to be relating to the frontline teams, the community groups, the external stakeholders. The aim was that these SCNs, starting with the core at the center, would be engaging as many Albertans as they could, and the aim was to make sure that networks were a structure that everybody could identify with. So we started about 5 years ago with the current strategic clinical network plan. There was the original 6, and the original 6 and I was part of the original 6, the bone and joint network, and we've been working forward from 2012 to present. And we are pretty excited that we have been able to expand and expand and expand. We have shown our value, and to date, Alberta Health Services, Alberta Health have supported us and have seen that this does work, and there is a return on the investment they're putting into these. This year, we launched our primary care network, which was a huge launch because primary care sits out there in the community, and they weren't really sure how much they wanted to play in the game. We have primary care representation on all of our networks. Every network has primary care representation, but there are unique issues in primary care that weren't being addressed, and we needed a network to do that. So this year we were able to launch the primary care integration network. So how do we make decisions in the network? How do we decide what we're going to do? We have a 4-step process. We look first to identify opportunities. And when we started this, actually, people were a little hesitant to bring opportunities forward. Now we're flooded with opportunities because people see that, oh, this is a way to get something done. And once they see that it works, opportunities come forward. But then you have to determine what are you going to work on. And we have a priority setting tool, a priority setting mechanism where we evaluate all these priorities. And our core committee will have robust discussions on, no, you should be working on shoulders. No, you should be working on backs. You should be doing these kind of things. And so we have a priority setting tool, and that tool will then filter all these ideas. And then we go to developing a business case. We co-develop a business case. So what does it look like? And what's it going to take? Cy Frank's idea was that we have a dragon's den, where we actually present our ideas and sell our ideas to our administrators, to our leaders, saying, you got to do this because this has huge impact. Because once they agree to it, then we got to deliver. And if you see, it's co-determine, co-develop, co-deliver. It's all working together because the networks in themselves don't have a lot of authority. We don't actually have hard dollars that we can put into other than a little bit of research dollars, but we have huge influence. We can bring the providers along. We can bring different people along, and we can help them work together. We can engage them. And that's why people want to work with us now, is because actually you can help make things happen. And this slide I just want to say that we're not just in the acute care. We're in right all the way through long-term care, community, and primary care. We have projects in all levels. Initially, we focused a lot on the acute care because that's where the dollars were. That's where the huge gains and that's some of the low-hanging fruit was fixing what we did in the hospitals. But some of the more difficult things to do were going out into the community and actually fixing some of the problems in the community. And this is a busy slide, and I'm not sure how Catherine is going to talk about this, other than up in the corner there you see lots of dollars saved, and that's probably what she wanted to say. We saved a lot of money, so my role is I'm an orthopedic surgeon. I'm a half-time clinician, and the other half-time I work in the network. And I should preface that I did work in the network. I resigned as of September. I've taken on a new role with Alberta Health Services, but for 5 years, this was my passion, and I still say it was one of the best jobs I ever had. It's the most fun I've ever had is being a clinical or medical director in a network, because you get to do all the fun things, and anybody in the room who's ever served as a chief medical officer, as a site chief, knows dealing with bad behavior and dealing with physicians who don't want to follow the rules. It's a nightmare compared to what we get to do in this world. And so this is what my network looks like. I am the senior medical director. I have a senior provincial director. We work in a dyad relationship. We have a scientific director who is on loan from the university, so that's a 0.4 position. We have a full-time assistant scientific director, and it was very important that we include the research, the scientific directors in everything we do, because they speak into what we do. And in the core committee, they have a huge voice. We also have an executive director, a manager, and an administrative support. So that's a small team. Every network is structured this way. It costs about $1 million to fund all of our activities. So it is an investment, but we think it's worth the investment. And on the other side, you see our strategic, the core committee, and we really report to our core committee. If I have something I want to do, I have to sell it to my core committee. I was just going to give a few examples of bone and joint successes. Our hip and knee work was the first work we started. We have a provincial care pathway. So everybody who does a hip and knee replacement follows that care pathway. It's updated twice a year with a clinical committee, and all of those sites get together twice a year. They have a balanced scorecard, and they have to work on different quality measures that they got to work on to improve. And we share our data. We have all the sites get their information, and they get to see, are they the best or the worst in the province, and where do they rate. And when they're sitting around in our meetings, they all sit at their own tables, but they are aware that the next table is the next hospital, and guess what? Their length of stay is a lot better than yours. Their readmission rate is making you look really bad. So there is some competition, and competition isn't bad. The surgeons, all of our surgeons in hip and knee get a report card. We call it continuous improvement reports, but what it is basically a report card. It tells me where I stand in the province. Am I the 20th percentile? Am I at the 80th percentile? And it tells me where I stand in my own hospital. Every hospital, every group, it has to be more than 5, because if it's less than 5, we don't report it as a group. But if it's more than 5, we report, and you get to see if you are how you rate. Of course, we all agree that our patients are much sicker than anybody else's, and that's why I didn't do as well. But the truth is that's not right. And we stratify as much as we can for comorbidities, for age, for BMI, for everything else. So those report cards do change behavior. And there is a lot of collaboration across the sites to work together to get a better job and to be better. This slide just shows that over the period of time we have made improvements. Our length of stay continues to drop, and that's worth millions. And I said $52 million value of just dropping the length of stay. Blood transfusions. Interesting when you realize that the other doctors in your hospital have a lot lower blood transfusion rate than you do. You start looking at it and trying to figure out why. And we averaged in those. There was about a $5 million savings in decreasing the transfusion rate. And we do measure and we try and report the savings. And at the same time, the readmission rate continues to drop. The second program that I'll mention is our fragility and stability program. We follow the National Care Pathway for Bone and Joint Canada, and that's implemented across the province. Everybody that does fractured hips has to follow that. We report on how they're doing. We report their time to the OR. We originally started with the 48-hour time to the OR. We dropped it to 36 hours because we saw the National Health Services dropping theirs, and we wanted to keep up. And I know in Ontario there's some sites that are down to 24 hours, and it's pretty good. There's pretty good evidence that the quicker you get them to the operating room and the faster you fix them and the quicker you mobilize them, the better they do. We also have a fracture liaison service, and what that is just coordinating the care and trying to identify those patients that need osteoporosis management and actually getting them started on their, and the 3I means that we actually we implement the changes in their care while they're in hospital. Catch a Break is a program that we have in our CAST clinics, and what we're trying to do there is pick up patients that come in with fragility fractures that are at risk for other fractures and making sure that their family physician knows about the osteoporosis. And this is another one of those fancy slides that my executive director loves to make. And I think they like to make it because when we make presentations, we're limited in about, we have 5 slides and that's all we're allowed. Here you give us so much time, but there they say you only get this many slides. So they put everything on one slide, and this is kind of shows the pathway of the hip fracture work. And really the transition back to the community is a big deal to us. Fixing the transition to the community has decreased our length of stay. And if we can work on that transition to the community, that's where we actually think some of the real gold is getting our patients back, because fixing them early, but then mobilizing them, but also getting them back to the community and along the full care pathway. I won't call it a journey; I'll call it a pathway. So I mentioned this only to. So these are some of the other areas we're working on. Lots of. Thank you. We've got a number of other areas. Spine access is one we're running spine clinics. We're working on the conservative management for osteoarthritis with the GLAD program that's called Good Living with Osteoarthritis from Denmark. We've got about 7 centers across the Alberta that are working on that. And our core committee has pushed us to get back into the community, and they want us to move out of the acute care and deal with things in the community because they said that's more important to our patients. So we have been successful, or we think we have, and we have a pretty good dollar amount to say that we are, and we have pretty good evidence that our satisfaction rates, whether they're truly the way we should measure them or not, I can't comment, but our patient reported outcomes continue to improve. So what led to that success? First thing is a culture of change. At the top of our organization, at the start of this, there had been a lot of change. Our CEOs had been changing, and the Minister of Health and the Deputy Minister had been changing repeatedly. But when you get below that level, there hadn't been a lot of change. And so we really needed to change the culture that things are going to change, and we need to change. Knowing that change is going to happen, and do you want to be part of it, or do you want to fight it? is a great discussion. And most physicians, when they present it in the right way, most nurses and caregivers do want to be part of the change, and they do want to speak into it. So a culture of change is one of the factors that is, for us, was very important. Support from multiple levels. You need support at the very beginning from your senior leaders. Your CEO and your senior leaders have to give this a stamp of approval, because until that happens, everybody else says, well, this is just another fairy tale. This isn't going to happen. It's just another shiny thing that's going to go away. There are clinical champions, and I know I heard some people say, well, it's really hard finding clinical champions. I actually think the clinical champions are out there. They just are very skeptical that they want to see the structure, and is this going to work, and is this worth my time? Because we've been burned a lot of times with clinical champions have been burned by starting things that just got put on the shelf. We need administrative buy-in. We call it bottom-up and top-down. So the administration below the senior leadership, your hospital directors, your operating room managers, those administrations have to actually buy in as well. And they have to get the message that we're in this together and we're going to work. So you need all levels of the organization, and we say communicate, communicate, communicate. You've got to share this vision, and everybody has to really understand. So we keep saying the same things over and over again to try and get the message across. I'm a strong believer in funding drives change. We've been able to change funding in select areas, and where I have, change happened. Like in my hip and knee clinics, we have a case rate. We have a case rate for in some of our other clinics. And when I can have a payment model that are paying for outcomes, it works. Where activity-based funding is rolling out, and it's some of these things are a lot slower than we wish. But where you do change funding, things happen faster. And you also have to realize that shared savings are important. What we did in hip and knee is you save that money, we're going to increase capacity. And so we were able to increase 35% capacity with only about 9% increase in beds. So we really did reinvest the savings into the system. Data. We need to use data as much as we can, be as smart about it as possible, because to convince people that we're going to change, they need some pretty good evidence. And so data for us is crucial. The more data we can get, and the better we are at using it and selling the change. And lastly, building a consensus across the province. Getting agreement from all players at all levels is probably one of the things that's the most important things in success to what we've been doing. It is hard because local autonomy is there. Each local hospital thinks they have the answer, and you really do need to balance the provincial priorities with the local initiatives, and that's a balance. It's not easy, and it's a battle, and we fight it all the time. So in summary, we have some examples of success. If I had to say what was the biggest outcome from strategic clinical networks in Alberta, I'd say our engagement efforts are probably the biggest success, and we truly have engaged. We have now people who want to be part of the networks. When I started, I couldn't convince people to be on the core committee. Now people are asking to be on the core committee because you're actually going to get, it's a structure where you're going to make a decision, and actually you're going to be able to track and follow it, and you're going to see what happens. So it's been fun, and it's been 5 years, and we've made some progress, but there's a lot left to done. So thank you very much.